Welcome to our video on potassium disorders. Let's begin. In this lecture, we'll talk about hypokalemia and hyperkalemia. For each of these conditions, we'll talk about their causes, clinical presentation, and management. Let's start with hypokalemia. Hypokalemia is defined as serum potassium levels less than 3.5. It can be caused by multiple different factors. Let's first talk about the causes of renal potassium loss. Patients with Cone syndrome can have hypokalemia because they produce excessive aldosterone from the adrenocortical tumor. Aldosterone stimulates potassium secretion from the principal cells of the collecting tubule. Fibromuscular dysplasia and renal artery atherosclerosis are examples of secondary hyperaldosteronism. Decreased renal blood flow activates renin-angiotensin-aldosterone system and causes hypokalemia by the same mechanism that we have already explained. Hypomagnesemia is commonly seen with hypokalemia due to concurrent loss of these electrolytes in conditions like diarrhea and diuretic use. Additionally, hypomagnesemia can secondarily cause hypokalemia because magnesium normally blocks the renal outer medullary potassium channel on the principal cell of collecting tubules. Hypomagnesemia disinhibits this channel, resulting in potassium wasting. Here we have an illustration showing how aldosterone stimulates potassium secretion from the principal cells of the collecting tubules. Let's recall that aldosterone stimulates the renal outer medullary potassium channels on the principal cells of the collecting tubule, inducing potassium secretion. As we already mentioned on the previous slide, anything that can activate renin-angiotensin-aldosterone system can potentially cause hypokalemia by this mechanism. This is the same illustration as the one on the previous slide. We'll use it here to explain how hypomagnesemia causes potassium wasting. Potassium is secreted via renal outer medullary potassium channel, abbreviated as ROMK channel, on the principal cells of the collecting tubules. Now, magnesium normally blocks potassium secretion by inhibiting these ROMK channels. As we already discussed in one of the previous slides, hypomagnesemia disinhibits this channel, resulting in potassium wasting. Renal potassium loss also occurs in type 1 and type 2 renal tubular acidosis. Type 1 renal tubular acidosis increases potassium secretion from the collecting tubule, while type 2 renal tubular acidosis prevents potassium reabsorption in the proximal convoluted tubule. Acetazolamide, loop, and thiazide diuretics activate renin-angiotensin-aldosterone system. Due to volume depletion, aldosterone in turn stimulates potassium secretion from the collecting tubule. Diabetic ketoacidosis causes osmotic diuresis. Glucose in the nephron lumen draws water and potassium from the blood to the nephron, resulting in potassium wasting. Finally, ureterosigmoidostomy causes potassium loss from the sigmoid colon. Sodium in the urine is reabsorbed in the large intestine. In exchange, potassium is secreted, causing hypokalemia. Let's talk about causes of hypokalemia due to redistribution. Epinephrine, insulin, and beta agonists activate sodium-potassium ATPase and drive potassium into the cells, causing hypokalemia. Additionally, alkalosis causes exchange of potassium for proton, resulting in hypokalemia. Let's illustrate what causes potassium to shift into the cell, resulting in hypokalemia. So here is a cell. The inside of the cell will be ICF, and outside of the cell will be ECF. Insulin, epinephrine, and beta agonists drive potassium into the cell by activating sodium-potassium ATPase. Additionally, alkalosis causes extracellular secretion of hydrogen ions in exchange for potassium. Extrarenal potassium loss occurs in laxative abuse, diarrhea, and excessive perspiration. This is because colonic fluid is rich in potassium, so increased frequency of bowel movements will cause potassium wasting. Additionally, sweat contains potassium, which is why excessive perspiration can cause hypokalemia. Decreased intake of potassium can rarely cause hypokalemia. Villus adenoma in the colon can secrete potassium-rich fluid, causing hypokalemia. Finally, enterocutaneous fistula will result in loss of potassium-rich secretions from the GI tract. Hypokalemia is commonly manifested as muscle cramps and weakness. Hypokalemia hyperpolarizes excitable tissues, including muscle, and makes it more difficult to fire action potentials. This is why patients with hypokalemia might have muscle weakness. The patient might also complain of palpitations due to concomitant arrhythmia. Low potassium levels usually cause U waves and flattened T waves on electrocardiography. Here we see the electrocardiogram showing U wave and the flattened T wave. These findings are characteristic of hypokalemia. Here we have the algorithm of hypokalemia. Let's discuss the diagnosis and management of hypokalemia based on this algorithm. When the patient presents with signs and symptoms of hypokalemia, such as weakness, fatigue, muscle cramps, and hyporeflexia, we should measure serum potassium to document hypokalemia. If serum potassium is normal, then we should check for the alternative causes of the patient's signs and symptoms. If serum potassium is lower than 3.5, then we should order electrocardiography to look for the changes characteristic of hypokalemia, like flattened T waves and the presence of U waves. If ECG is abnormal, we should immediately start high-dose intravenous potassium. If ECG is normal, then we should order the basic metabolic panel to check if the patient has true hypokalemia. We should also check magnesium because we already explained previously, hypomagnesium can cause renal potassium wasting. Arterial blood gases should be ordered to check for underlying acid-base disturbances. Finally, we should check the medication history. The patient may have taken insulin, beta agonists, or epinephrine, all of which can cause hypokalemia due to intracellular potassium transfer. If hypomagnesemia is discovered, we should start magnesium supplementation. Metabolic alkalosis can also be detected and implicated in hypokalemia. If the patient has taken epinephrine, insulin, or beta agonists, then we need to start potassium supplementation. In case of true potassium depletion, we should measure urine potassium to differentiate extrarenal from renal potassium loss. This will help us identify the cause of hypokalemia. Urine potassium levels of less than 20 indicate extrarenal potassium loss. This can be caused by laxative abuse, diarrhea, excessive perspiration, decreased intake, or villus adenoma. In any of these cases, we should start potassium repletion. If urine potassium levels are more than 20, then we are dealing with the renal potassium loss. Conditions causing renal potassium loss include diuretics, type 1 and 2 renal tubular acidosis, and diabetic ketoacidosis. We should start potassium repletion in these conditions as well. Let's talk about the route of administration of potassium depending on severity of hypokalemia. Asymptomatic patients are usually treated with oral potassium supplements, while symptomatic patients are treated with high-dose oral or IV potassium supplements. Regardless, we should check the serum potassium every 2 to 4 hours in order to avoid hyperkalemia. A 35-year-old woman comes to the physician on a follow-up visit for hypertension. Her blood pressure ranges from 170/90 to 190/95. Physical exam reveals carotid and epigastric bruits. Laboratory findings are significant for metabolic alkalosis and hypokalemia. What is the most likely pathophysiology of this patient's electrolyte imbalance? This relatively young patient presents with stage 2 hypertension. The physical exam reveals carotid and epigastric bruits that indicate a possible narrowing in carotid and renal arteries, respectively. Laboratory findings are significant for metabolic alkalosis and hypokalemia. The question asks the most likely pathophysiology of hypokalemia in this particular patient. All these findings indicate the presence of fibromuscular dysplasia. Fibromuscular dysplasia causes alternating narrowing and dilation of renal and carotid arteries. Reduced renal blood flow activates renin-angiotensin-aldosterone system. Consequently, aldosterone stimulates potassium secretion of potassium from the principal cells of collecting tubule, and the patient develops hypokalemia. Let's move on to hyperkalemia. Hyperkalemia is defined as serum potassium of greater than 5. Just like hypokalemia, hyperkalemia has many causes. Let's first discuss the causes of hyperkalemia due to redistribution of potassium. Metabolic acidosis due to acute or chronic kidney disease can result in hyperkalemia because acidosis induces intracellular hydrogen transport in exchange for extracellular potassium efflux. Cell lysis can also cause hyperkalemia by spilling the intracellular potassium in the blood. This can happen in tumor lysis syndrome and rhabdomyolysis. Hyperosmolarity draws water and potassium from the intracellular compartment to the extracellular compartment, inducing hyperkalemia. Beta blockers and digoxin block sodium-potassium ATPase. Therefore, potassium stays out of the cell, causing hyperkalemia. Succinylcholine, which is a depolarizing neuromuscular blocker, opens up the nicotinic acetylcholine receptors. Normally, nicotinic acetylcholine receptors cause sodium influx and potassium efflux. Excessive potassium efflux into the blood induced by succinylcholine will cause hyperkalemia. Again, let's illustrate what causes potassium to shift out of the cell, resulting in hyperkalemia. So, here we have a cell, and this portion is ICF, and this one is ECF. Hyperosmolarity drives potassium out of the cell by drawing intracellular water into the extracellular compartment, which leads to the formation of potassium gradient. Cell lysis spills the intracellular potassium into the plasma. Finally, acidosis causes intracellular transfer of hydrogen ions in exchange for potassium. Let's illustrate how beta blockers and digoxin cause hyperkalemia. Both of these drugs block sodium-potassium ATPase. Therefore, potassium is retained in the blood, causing hyperkalemia. Let's now talk about the causes of hyperkalemia that are associated with high or normal aldosterone. Potassium-sparing diuretics like spironolactone, eplerenone, amiloride, and triamterene blunt the effect of aldosterone on the principal cells of the collecting tubule. Therefore, potassium can no longer be secreted from the collecting tubule, resulting in hyperkalemia. Finally, we talk about the causes of hyperkalemia with low aldosterone. ACE inhibitors and angiotensin receptor blockers decrease aldosterone production. Therefore, aldosterone is no longer stimulating potassium secretion from the collecting tubule. Hyporeninemic hypoaldosteronism is common in diabetes and results in hyperkalemia by the same mechanism that we already discussed for ACE inhibitors and angiotensin receptor blockers. Lastly, Addison's disease, which is primary adrenal insufficiency, also causes decreased aldosterone production and therefore hyperkalemia. Hyperkalemia, just like hypokalemia, can present with muscle weakness. High potassium levels cause stabilization of fast sodium channels in closed conformation. Therefore, action potentials do not propagate anymore. Hyperkalemia can also manifest with palpitations due to arrhythmia. There is a specific sequence of electrocardiographic changes associated with hyperkalemia. First, we have a prolonged PR interval and a peaked T wave. Then, P wave is lost and we get an ST elevation. Widened QRS complex with bundle branch or fascicular block can occur if serum potassium levels rise further. Finally, ECG shows the sine wave pattern in the setting of severe hyperkalemia. Here we see the typical ECG changes associated with hyperkalemia. Please note the peaked T waves and the absent P waves. Here we have the algorithm of hyperkalemia. Let's discuss the diagnosis and management of hyperkalemia based on this algorithm. When the patient presents with signs and symptoms of hyperkalemia, such as weakness, abdominal pain, vomiting, and diarrhea, we should measure serum potassium to document hyperkalemia. If serum potassium is normal, then we should check for the alternative causes of the patient's signs and symptoms. If serum potassium is more than 5, then we should order electrocardiography to look for the changes characteristic of hyperkalemia like peak T waves. If ECG is abnormal, we should immediately start intravenous calcium gluconate to stabilize the myocardium and prevent life-threatening arrhythmias. If ECG is normal, then we should order basic metabolic panel to check if the patient has true hyperkalemia. Arterial blood gases should be ordered to check for underlying acid-base disturbances. We should check the medication history. The patient may have been administered beta blockers, digitalis, or succinylcholine, all of which can cause hyperkalemia. We should also check creatinine because chronic kidney disease can cause hyperkalemia. If arterial blood gases reveal metabolic acidosis, we should treat the patient's underlying condition. Beta blocker toxicity is treated with atropine that raises the heart rate, glucagon, and normal saline. Digitalis toxicity is treated with digoxin immune Fab fragment, which binds to and neutralizes digoxin. In all these scenarios, we also need to initiate rapid-acting agents for lowering potassium, in addition to the specific treatment. Succinylcholine toxicity is treated with supportive measures like fluids and mechanical ventilation. In case of true potassium excess, we should measure aldosterone. If hyperkalemia is accompanied by hypoaldosteronism, then the underlying cause of hyperkalemia may be ACE inhibitors, ARBs, Addison's disease, or hyporeninemic hypoaldosteronism. If hyperkalemia is accompanied by normal or high aldosterone, then the most likely underlying cause is the use of potassium-sparing diuretics. Now let's talk about how we treat hyperkalemia. As we already mentioned, first we need to administer IV calcium gluconate to prevent life-threatening arrhythmias. Rapid-acting options for treatment of hyperkalemia also include insulin with glucose or beta-2 agonists. Both of these medications will drive potassium into the cells. Sodium bicarbonate will increase the blood pH, forcing the hydrogen ions out of the cell in exchange for potassium. Rapid-acting options should be followed by slow-acting options. Loop diuretics activate renin-angiotensin-aldosterone system and therefore increase potassium secretion from the distal tubule. Cation exchange resins like K-exalate or patiromer induce potassium excretion in stool. Finally, we could use hemodialysis to remove excess potassium from the body. Let's end our lecture with a board-style question. An 85-year-old man is brought to the emergency department due to palpitations and shortness of breath. He has stage 4 chronic kidney disease and he missed the last 3 dialysis sessions. His past medical history is also significant for hypertension and congestive heart failure, treated with enalapril, spironolactone, and metoprolol. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 100/80, a heart rate of 40, and a respiratory rate of 25. Electrocardiography shows prolonged PR interval and peaked T waves. His serum potassium levels are 7.5. Which of the following should be administered first to this patient? A. Insulin with glucose. B. Calcium gluconate. C. Patiromer. D. Sodium polystyrene sulfonate. The patient missed the last 3 dialysis sessions and now he presents with palpitations and shortness of breath. Electrocardiography shows prolonged PR interval and peaked T waves. His serum potassium levels are 7.5. All these findings are consistent with hyperkalemia. The first-line therapy for symptomatic hyperkalemia is IV calcium gluconate to stabilize the cardiac membranes and treat the arrhythmia. Therefore, the correct answer is option B, calcium gluconate. Here's the algorithm reminding us of the causes and the management of hyperkalemia. Let's discuss why other options are incorrect. Option A, insulin with glucose, is a rapid-acting treatment option for hyperkalemia because insulin shifts potassium in the cells. However, the top priority in symptomatic hyperkalemia is to protect the myocardium from arrhythmias. Therefore, calcium gluconate should be administered first. Option C, patiramir, and D, sodium polystyrene sulfonates, are slow-acting cation exchange resins that bind to potassium in the gastrointestinal tract and remove it from the gut. They would be considered only after calcium gluconate and insulin therapy. And that concludes our lecture on potassium, magnesium, and phosphate disorders.